Nowadays, phacoemulsification is the most commonly performed cataract surgery in ophthalmology. However, despite tremendous technical and technological advancements, posterior capsular rent (PCR) still occurs. Although several factors can contribute to PCR during phacoemulsification, one of the crucial factors is the surgeon's experience. For a junior surgeon, the first challenge is to early recognize that the capsule is broken. Most PC tears are small in the beginning. However, without early recognition, the surgical result will likely be disastrous. In this video, the junior surgeon encountered a small PCR while doing phacoemulsification. Early warning signs and several surgical tips are described in this video regarding how to manage PCR and optimize the outcome. In the beginning, the junior surgeon did pretty well. But when she was removing the last fragment of nucleus, a sudden deepening of the anterior chamber occurs, and the posterior capsule bows posteriorly. What happened? A focal sharp red reflex zone behind the residual lens material can be identified. You'll find it's hard to focus on the hole. Certainly, early recognition will limit the problems. Pausing for a moment and identifying the PCR are very important. Inject dispersive viscoelastic into the area of posterior capsule defect through the side port incision. Protect the tear from extension and tamponade vitreous from coming into the anterior chamber. Rescue. Fill the anterior chamber with dispersive viscoelastic, thereby trapping residual nuclear and epinuclear fragments together and pushing lens fragments away from the hole. Then apply phaco-tip carefully along the edge of the nuclear fragment. Use the chopper as an assistant to move the fragment toward phaco-tip. Here the residual nucleus is removed smoothly without vitreous incarceration. Inject dispersive viscoelastic into the AC and fill the retrocapsule space insulate from vitreous prolapse. At the same time, lowering the IOP and decreasing the vacuum. Alternatively, an experienced surgeon may control vacuum through the foot pedal. Tips for removal of residual cortex without extending PCR. First, radial aspiration of the cortex should be stripped toward the rent. Any force generated away from it will cause its extension. Second, the aspiration rate must be very slow and IOP should be maintained low to prevent pressurizing the anterior segment and driving the cortex into the vitreous cavity. In addition, be sure to refill dispersive viscoelastic whenever there's not enough tamponade between the IA and posterior capsule. Vitreous strands are often hard to see. If you accidentally grab vitreous, the vacuum will rise up immediately, and you have to reflux aspiration right away. If the rent is kept small and prolapsed vitreous is little, try to fill the anterior chamber and bag with dispersive viscoelastic. Otherwise, an anterior vitrectomy should be launched. Use cotton swab to test if there are vitreous strains incarcerated at the incision site. Since the posterior capsule hole is stable and small for now, IOL implantation can be performed. The next question is, how to choose IOL? In this situation, we should consider two things: the posterior support of IOL and anterior capsular hexis. Here we made a chart for the selection of IOL. If the tear is small and the posterior capsule can still provide sufficient support, IOL can be placed into the bag. If it's a medium tear without zonular weakness and the CCC is well positioned in the center and smaller than the optic, the best option is to place the one-piece IOL in the bag and do a reversed optic capture. In cases of a large tear or tear with peripheral extension, the three-piece lens is advised to be used and placed in the ciliary sulcus if there is sufficient zonular support. Furthermore, If the situation is worse or complicated, a suture IOL or ACIOL may be needed. Now we can apply this chart to this case. The patient has corneal astigmatism around -2 diopter. Since the posterior capsule hole is small, zonial is intact, and CCC is central and complete, I placed a toric IOL in the capsular bag. Rotate the toric lens to be aligned with steep axis. Avoid downward pushing force toward the capsule. Placement of the IA tip on the anterior optic of the IOL for removal of viscoelastic as much as we can do. Close wound with hydration. Lastly, adjusted the toric lens aligned with green line at the steep astigmatism axis again with a blunt tip cannula through the side pore incision and ensure that the main incision is completely watertight. The PCR remains the same after removing nucleus, after removing cortex, and after IOL implantation. The pupil is round and the posterior chamber intraocular lens is well centered. Follow-up refractive outcome is -0.25 diopter. Uncorrected vision from 20/40 on day 1 to 20/20 5 months later. The eventual outcome was no different from that of an uncomplicated case. Most posterior capsule tears are small in the beginning. Early recognition can limit the consequential complications. However, it requires the surgeon's alertness and experience. Once any doubts arise, immediately stopping all aspiration and identifying the tear are the first steps to prevent serious complications with a higher incidence of permanent visual disability. Again, the tear is small in the beginning. Early recognition can limit the consequential complications. Improper management may lead to advanced complications. Early recognition of PCR with appropriate modification of the surgical plan is key to a good postoperative outcome.